A violent, heavy blow to the human face happens in just a fraction of a second, transferring massive energy. The surface bruising you see in the mirror is deceptive. The true danger is the kinetic shockwave traveling deep into the skull. When that energy hits, the eye undergoes a cascading sequence of structural failures, moving from the outer defenses towards the core. We will follow this kinetic energy through every layer of the eye to see exactly where and how it breaks the visual system. Identifying these specific internal breaches within the first few hours is the only way to prevent permanent vision loss. The orbital floor is the first line of defense. Under a heavy blow, this thin bone shatters to absorb severe intraorbital pressure. The blowout creates a physical cavity. Orbital contents prolapse downward into it, resulting in an ophthalmos, where the eyeball sinks backward and down, often causing double vision. Check for numbness in the cheek, lower lid, or side of the mouth. This indicates the fractured bone has damaged the infraorbital nerve. This specific injury mandates an urgent surgical consult to install supportive plates, along with a prescription for oral antibiotics to prevent deep tissue infection. The patient must be warned to never blow their nose. Doing so forces air through the shattered bone directly into the surrounding orbital tissues. When the eye sinks and the cheek goes numb, the orbital structure has failed. These patients require surgical reinforcement to restore the globe's position. Moving past the bone to the immediate surface of the eye, trauma often manifests as rapid lid swelling, ecchymosis, and surface bleeding. A standard subconjunctival hemorrhage is typically benign and managed with cold compresses for the first 24 hours. The critical exception is a hemorrhage lacking a definable posterior border. This indicates blood is spreading from the deep recesses behind the visible sclera. If there is no obvious cause for this boundless bleed, it requires immediate deeper imaging and a review of any blood thinners the patient may be taking. Most surface blood is a cosmetic issue, but hidden borders indicate a dangerous, unseen posterior rupture. As the shockwave enters the anterior chamber, the impact compresses the cornea, forcing aqueous fluid violently backward against the iris. This fluid surge causes iridodialysis, physically tearing the iris from its scleral root. This distorts the pupil, leading to severe glare sensitivity and double vision. The fluid can also dissect into the ciliary body, a condition called angle recession. This creates a high risk for silent, unilateral glaucoma that can emerge months or years later. Hyphema represents the most visible internal threat. Blood pools directly inside the chamber, where it can stain the cornea and cause dangerous spikes in intraocular pressure. Managing a severe hyphema requires hospital admission and complete bed rest at an incline. To prevent rebleeding, aspirin and NSAIDs are strictly prohibited. Chamber damage turns the eye's own fluids into a weapon against itself, requiring strict immobilization to prevent blinding pressure spikes. The final remnants of the shockwave travel to the center of the eye, striking the crystalline lens. The force can compress the iris against the lens so hard it stamps a circular ring of brown pigment directly onto the clear surface, a marker known as a Vossius ring. The pressure puts massive strain on the suspensory ligaments. These thread-like zonules snap, causing the lens to detach. As the lens falls deeper into the posterior cavity, the front fluid space visibly widens, creating a deeper anterior chamber and sudden extreme shifts in nearsightedness. Any damaged lens fibers will rapidly hydrate and swell, leading to immediate or delayed traumatic cataracts. A disrupted lens ruins the eye's optics and demands urgent surgical extraction. Every blunt impact triggers a rapid sequence of internal mechanical failures that the outward swelling often conceals. Differentiating between a simple surface bleed and a deep, boundless hemorrhage dictates the immediate course of treatment. Spotting a pigment ring or a sunken orbit dictates the urgency of intervention, moving high-risk patients towards surgical repair before damage becomes irreversible. Remember the critical rule for heavy facial impacts: never let the patient blow their nose, as it forces air pressure into compromised tissues. These markers allow you to recognize a vision-threatening emergency when seconds count.